All right. So good afternoon, everyone, and welcome to the Roundtable with Ontario's Chief Nurse, Dr. Karima Velji. My name is Sandra Li-James, and I'm the VP of Quality Best Practice in Education and the Chief Nursing Officer at VHA. Before we start, just a few housekeeping items. Please turn on your video if you're able to and keep yourself on mute unless you're speaking. And please feel free to use the chat function or raise your hand if you'd like to share. And we would like to start today's event by acknowledging that we're living and working in Indigenous land. Many of us are joining from the Toronto and GTA regions today, which are the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. So thank you for acknowledging the land with me this afternoon. I would say since joining VHA, I've come to appreciate the important role that VHA nurses play in our clients' healthcare journey. So home care nursing is very complex, and our nurses are often working in unfamiliar and sometimes challenging situations in people's home or in unique healthcare settings. They work independently without colleagues down the hall to call upon, and they're often managing multiple complex medical and psychosocial issues, and which all of this makes home care nursing a truly unique specialty. I know our nurses are pleased to have the opportunity with you today, Dr. Velji, and to hear from you as well. We do have, to start us off, we have a brief video about nursing at VHA that demonstrates the diversity of a home and community care setting that we'd like to share. Thank you, Isabel. And our president and CEO, Dr. Catherine Nicol, who's also a nurse, she's able to join us today. And I invite her to say a few words before we begin. Catherine?
Thank you, Sandra. Hi, Karima.
Hi.
My pleasure to host you at VHA virtually this afternoon. So wonderful to see a team of nurses here willing to share their stories and experiences of home care nursing with you. As Sandra said, I am a nurse, so near and dear to my heart that you are joining us. And I just wanted to say I couldn't be more pleased that you are our Chief of Nursing and Professional Practice in Ontario, but also that you are an Assistant Deputy Minister at the Ministry of Health responsible for capacity and health workforce planning, because you know, and we all know, how much we need to look after our nurses, recruit them, retain them, celebrate them, acknowledgement, and I'm so delighted that you have that under your very prestigious portfolio, and I really look forward to seeing the work that you will be leading on not only our behalf, but behalf of all nurses in the province of Ontario. So my thanks, and now I'm going into silent mode, and I'm really looking forward to hearing the conversation. Thank you.
Thank you, Catherine. And Catherine did a wonderful job introducing you. So over to you, Karima, and welcome and to say a few words.
Well, my first word will be thank you. And how wowed I am by your video. The words were so powerful. In that video, I was looking at each word, and I think it was very purposefully there. It started with innovation, I think. Empowered, we make a difference, we are a team, very powerful messages. And right off, I would say to you, those are the messages by which we should be portraying nurses in this province. I usually don't start with this statement, but I'll make the statement now that I've seen your video that it bothers me sometimes, the way in which we are portraying and positioning nursing in the province. Those who speak for us in media and so on, no doubt are bringing attention to some very important issues and urgent issues that need to be dealt with. But that has become the predominant rhetoric, the view you would have if you were to just look at how it's being portrayed in mainstream media, is we are a downtrodden profession, hurting, burned out, exhausted. We are leaving the profession in droves. It's such a downer. Such a downer the way we are being represented, and unfortunately the amazing work of nurses every day has become invisible as a result. The fact that people are coming to work, working in difficult circumstances, innovating and making a difference to their patients, all of your work, unfortunately I don't see it in the way things are being publicly portrayed in the media, because it has become very, what shall I say, a narrow focused view of the profession. And well-meaning, I mean, we are bringing attention to the issues that need to be attended to, like Bill 124, like the workplace environments that have to be sorted out and so on. But that's not the only story of nursing. The story is what I saw in the video. And no doubt you'll be sharing some of your stories with me. I've done so many roundtables now and interacted with about 500 nurses at least at the point of care. And every roundtable, there is no doubt people tell me they give me advice, but equally they tell me the work that they are proud of. And I want to honor that. I want to make sure that thing does not get invisible. So whatever you do, folks, portraying that positive spirit of care that is still alive in all of us, it's very crucial that we position it out there and share your stories and your work. So thank you for doing that. And thank you for giving me the time today. Because I started my role in August of 2022. It's a new role at the ministry. I'm a nurse as well, and I want to make sure I've been in care environments all my life and a practitioner for almost more than half of my career before I moved to administration. So this point of care work, the work of patient care, is where I'm grounded. Everything starts and stops with patients for me and the people who are caring for patients. So I want to make sure in my role at the ministry, I stay real in my work. I don't become bureaucratic. I don't get removed from reality. So this listening work will be ongoing for me. I continue to listen to people who are doing the care at the point of care. It's very crucial for me because I think that's where the wisdom is. If I don't tap that wisdom, that's where the collective is. That's where the movement's potentials are. We must work on this path together. So thank you in advance for giving me the time and the advice today. I thought I would introduce you to my role briefly and what's under my portfolio. It'll give you a sense, and then tell you a little bit about the 6 buckets of innovation that we are trying to move our strategies through, and give you a glimpse on what each of these examples of the innovations that are in each of the 6 buckets, and then open up to Q&A. So the role started in August of 2022, so just 6 months now in the role. It's a new role at the ministry. As Sandra and Catherine have noted, it's an ADM role. So for the first time in our history, the role has been positioned in the right place at the ministry, at the senior management level, reporting to the deputy directly and sitting at the executive tables at the ministry as well. So not only at the senior management table, at the highest of the decision-making tables at the ministry is where the role is positioned. So there is no excuse now. Like, you can't say I wasn't positioned properly to do the work. No, I'm positioned properly to do the work. The work now needs to be done. The reason I ventured into this role was I was finding myself at that place where I knew I have 5-7 more years left in me to do paid career role. Where am I going to spend my time and effort? And myself and my mentors led me to this path of use your knowledge, use the skills you've gathered over years, and make a difference to the most wicked issue of the day, which is our health human resources. It needs a lot of attention, a lot of innovative thinking. So I want to be in the service of that to try and make some big difference in this area, because I do believe the opportunity is now to walk through some windows of opportunity that are open. In every crisis I find is an opportunity, is a silver lining, a door that's showing you a way. And some leaders are able to see those doors, and unfortunately, some leaders don't. And the doors close, the timing, the opportunity closes, and then we are left with the same old conversations we've been having since I've been a nurse 30 years. Same old rhetoric, conversation, nothing really moves forward. And I'm getting very impatient as I age on that front. Like, let's get something done, folks. And this is the time to get it done. Things we've been a little bit paralyzed on. If we don't do it now, when will we do it? When will we do it, if not now? So, long story short, I've done a lot of reading, a lot of analysis, a lot of looking at what other jurisdictions do. The learning has been immense for me as I've come into the role, because I've never been in government. I've always been an executive or a nurse in a hospital, for example. And in some community settings, I've done voluntary work all around the world, but government is different. It's a different thing. So lots of learning, lots of understanding what has to happen here, but factual understanding. I want to be driven by facts and evidence, not rhetoric, not myths. And the myths are alive and well, folks. So to cut a long story short, my conclusion has come to a place where I would say, there is a dire urgency in health human resources, folks. When we say there is a crisis, there is. We can't whitewash it. We can't give it a positive word and think it will disappear. There is an urgent situation in health human resources in every damn jurisdiction in the world. So we are not different. We are experiencing what the whole world is experiencing, a dire need for more health human resources and innovations in health human resources. I've also now come to understand, looking at the current gaps in the healthcare system, the current vacancies, sick time, agency use, etc., that using the mantra of recruitment and retention is old-fashioned. We will never recruit and never retain our way to our current gaps or to our future gaps. When you project our gaps to 10 years, we've done these projections, and you impose the needs of the growing population in Ontario and the growing population of seniors in Ontario. The gaps are so mind-boggling. Worldwide, the gaps are in the millions and millions of numbers. And in Ontario, it's thousands and thousands of people we will need in the future in the system. Traditional approaches will not take us there. So the word and the name of the game is innovation. Moving innovations in 6 buckets, and I'll tell you quickly what they are. So the first one is education innovation. So activating more training seats for nurses and others in the system, but ensuring the seats are tied to innovative approaches. And by that, I mean any possibility to compress an education program, do multiple intakes in an education program, reimagine how we do clinical placements in our program so that we graduate people faster is a crucial consideration. Otherwise, we will be replacing nurses with other people. In the province, we will not have enough of anyone, any nurse, for any setting. So it's very crucial we get into the business of activating more seats and fast forwarding those seats without compromising the education standard. So I'm not saying do away with the degree preparation for nurses. No, it's baccalaureate entry to practice, but can we deliver the program in 3 years? Can we do multiple intakes so that you don't have a one time a year intake, and you are putting more people through the system We need fast delivery of HHR. So with the plan that was announced last week, the Your Health plan, you saw we've activated further now, 1,000 registered nursing seats, 500 RPN seats, and 150 nurse practitioner seats in the province. And we have an equal amount of expansion going on the physician side and physician assistants as well. The second one for nursing is scope of practice enhancements. Folks, we have to find our rightful place in the system. And by the way, I applaud you for being in the space you have selected, home and community care. For me, not that I've practiced in that area as you are practicing, but I do feel that is the blue ocean of nursing. If you have not read the book Blue Ocean Strategy, read it. It tells me you have found your rightful place in the system. Because I do believe nurses with the highest knowledge we have now, we are the most educated in our history now with the current cohort that we have. The public trusts us the most. We are the highest in the public trusts as professions they trust. We touch patient care on a 24/7 basis in all sectors. We are a powerful entity. There are 5 nurses for every physician in Ontario. The highest number of people who touch healthcare. If we unleash ourselves differently, the opportunity for patient care will be boundless. But we have to be willing to put the mirror to ourselves and say, in a scarcity environment, what choices are we going to make in this profession? Where should nurses be? Should they continue to be mostly in hospitals, where most of the nurses are in hospitals at the moment and long-term care facilities? Or do we, in a scarcity environment, actually make a choice and say, actually, if I have 10 nurses, UHN, St. Mike's, whoever, I'm going to take 5 or 6 of them and put them in community, because then I can avoid people's visits to hospitals. This upstream, purely beautiful nursing work that's not about tasks. It's nursing assessment, nursing intervention. It's the work you do for your patients. This is the future that's staring at us. And then we want to push on scope of practice as our second bucket of innovation and make sure you are working at the top of license scope. So we are going to move forward with RN prescribing in Ontario. We are going to move forward with RPN initiation, which means, for some things that you wish to do for your patients, you can exercise your independent knowledge, skill, and judgment. You don't need an RN to delegate that act to you. You have the knowledge, skill, and judgment to start a little IV or put oxygen by nasal prongs on patients who are surely. So it's taking those barriers away so nurses are unleashed and they are fully in their glory, basically exercising their full knowledge, skill, and judgment. Because most of our work now should not be directed by physicians. If you look at a hospital, 80–90% of the work we do there is someone writes an order and we follow it. The time for that is gone, folks. We have to be in our full glory as a profession, making a difference to patient care. So community is a great place to unleash the potential for nurses, because the same power hierarchies don't exist there. You are allowed to do what you need to do, which is phenomenal should you choose to do it. The third one is expedited pathways for international nurses. And I say it's a sin. It's a sin if an international nurse is sitting at home waiting to be registered when we are canceling services to patients, like surgeries, or making them wait on wait lists when their nurse is ready to practice. Let's fast forward their registration. Folks, how does the US do it? When they poach our nurses, do you think they put them through a difficult process of immigration and registration? No, they recognize the Canadian license and the nurse starts working. I think we have to be open to this idea for international nurses and not put all this systemic bias and racist kind of approaches that are in place now, honestly, like there are 5,000, 6,000 international nurses yet waiting at home, waiting to be registered. Let's get them to work. Fast forward the registration pathway and stop the barriers. And we've issued, our minister has issued directives to the College of Nurses and the College of Physicians and Surgeons, directing them to activate their pathways, remove the language barrier, remove the work experience barrier, remove the systemic biases in the system, folks. It's systemic racism, some of the stuff we see. It's our great need to, in the name of patient safety, to keep foreigners out of our system. It has to stop. The fourth idea or the fourth bucket of innovation is what we call Ontario First or as of right. As of right means anything we should be moving forward as a country, we are going to continue to sit at those tables in Canada, at the what we call the federal provincial tables, but Ontario is going to start to take a risk and show the way how to do it. So you saw last week we tabled legislation in Ontario whereby, if passed, and it will pass, nurses in other jurisdictions in Canada who are members in good standing can come and start to work in Ontario without having a registration, but eventually they should get registered with the college. So while you are awaiting your registration, come and start working with us. You are a nurse in Manitoba, registered and in good standing. A nurse in BC, a nurse in Nova Scotia. I'm not going to come and poach you, nor am I going to poach international nurses because I think countries need them. So I always work within the WHO ethical guidelines for ethical recruitment. But should you wish to be here, my job is to take your barrier away. And it's crucial that we do that not only at the ministry, college level, but every organization tries to make that pathway easy. The last two areas are team-based approach to care. You know what team-based approach is because you can't work without a team-based environment. We are very serious about it. In the pandemic, during the pandemic early stages, we had unleashed team-based models of care phenomenal, safely in this province. And then we took steps back. Unfortunately, we reversed some of them because then we were back in our old games of saying, but this is my bargaining unit work and you can't ambulate patients and you can't feed patients. You know what? Wake up and smell the coffee. We don't have enough numbers of anybody right now to be giving exceptional care to patients. We need all hands on deck and a team-based approach to care. I have no trouble with an OT helping a nursing team with activities of daily living for a patient. Yeah, help us feed the patient, help us toilet the patient, help us activate the patient. So what? It's not a sacred only our job. Because unfortunately, those tasks are getting, interventions are getting shortchanged because of the shortage. People don't get ambulated. They linger in beds. They don't get fed. There's a choice we have to make here. Are we going to allow others in so that we are a team-based approach, or are we going to hold on to our silos and not enable this more patient-centered approach? And then the last thing is what I call the retention distribution innovation bucket. In this sits some of the more wicked things that I'm trying to push. And these are the hardest things to push, I have to tell you. So we are pushing a lot of thinking on competitive compensation for nurses, for example, in this bucket, because if we are not competitive in our compensation, this is the basic Maslow hierarchy. At the basic of levels, if you don't have a competitive compensation environment in this economy, you cannot retain our nurses. It's so simple. So lots of thinking on competitive compensation, wage harmonization across sectors, which will be music to your ears, because why should a home care nurse be paid a third less than a hospital nurse. Like, I've never understood it. The toughest work sometimes, as you know, is in the community, in long-term care, because the same safeguards are not there. The same team is not wrapping around you. You are it. You are it. In the whatever, if it's an unsafe situation, a complex patient situation, you are managing it. That's as complex as it gets. And then we remunerate people like you a third less. We cannot create integrated care if we don't do wage harmonization. And it's not going to be an easy lift, folks. I'm being very honest with, especially when I speak to nursing groups, I want to be authentic and honest with you. This is going to take some work for us to ensure, sorry, there are no second-class citizens in nursing, depending on the sector. It's very simple, and we need to deal with issues like wage harmonization, and then also giving a lot of thought to distribution of the workforce, both for regional inequities that I see, but also sector inequities. If I think there's an issue of HHR in the hospitals, you know what it is. You can triple that, quadruple that for long-term care and home care. It's dire, because competitively, you're disadvantaged to begin with to attract people to your sectors. So we have a lot of work to do, folks, to lead our decision makers on the right path. But I have to tell you, so far, I've pushed on all the 6 buckets, and all my 6 buckets are moving. This is the window and the door that's open. We will get support now that we've never gotten before, both from government, but also from the stakeholders. The usual ways of resisting things are not there. People are more willing to try new things. All of a sudden, my screen is lost, but can you still hear me?
Yep, you're back now.
Okay.
Oh.
It did go black for some
It
reason.
did, right? My screen is still black, so let me see what I can do here. Because oh, there you are, all of you are back. Okay, these are the wonders of technology. So I will stop because I can go on, and I don't want to be in lecture mode, but I hope I've shared or given you a glimpse of things I'm thinking about, but the specific strategies we are moving on and the innovations that we are trying to drive. And then what are some visible things, but also some tough things that we will all need to work on to get the supports we need to make good things happen in Ontario. So with that, I'm going to turn over to our discussion. Lots of questions, I suppose, were shared with you, but really, I want to hear from you 2 things. What are you proud of? What innovations do you wish to share with me? Because they are very informative to me. And secondly, what is the advice you want to leave me with? What the key nuggets, the key sage advice and considerations that you want to place for me as well? So over back to Sandra to facilitate.
Okay, thank you so much. Thank you for sharing your vision and your focus of work. Definitely, you can lean on our point of care nurses anytime to help inform your, your strategies. And I think one of the things what we will do, I would say there are a few nurses, Karima, if you're okay with this, who have prepared. They wanted to share their stories, and through their stories, you will see some of the different innovations. So, in terms of what they are doing and what they're facing, that may give you a glimpse, and that will take a small portion of the time, and then we'll open it up if that's okay with you. We'll
Of course.
yeah, we'll start with I'll call upon Chelsea Braun to share. Chelsea is an RN with a background in pediatric palliative care. And so Chelsea, in your time at VHA, what opportunities have you noticed in the home care space?
Thanks for having me. So I am a visiting nurse in the palliative care program, specifically in Scarborough. So that's the Central East home care region. And it's such a special place to be with people at the end of their life in their home. A lot of the data that we've collected through our team shows that like more than 80% of people want to die at home. That's where they feel most comfortable. And the hugest barrier to that, I mean, and like system wide, that's a good thing. It's more cost effective. It's a good location of care for people, but the barriers to that happening are always a lack of skilled staff available to care for them, and like a lack of coordination of those services. So it's very, very siloed, I find, in home care. There's home and community care, there's the different agencies, there's the, you know, physician groups, and everybody's kind of trying to work together to coordinate care, but it's all these separate teams. And I know there's people on the call from Toronto Central who have this really great integrated team and the care coordinator, the nursing agency, and the physicians, they all work together to provide a lot more seamless care. And I think that's something that could be replicated in every region. I know in Scarborough, we're trying very hard to make that a reality, but it's been really tough because of the fact that it's so siloed, and breaking down those walls and getting all of the partners at the table to make that happen has been really challenging. And then I think, as you spoke to it, because, you know, the sector is paid so much less, it's so hard to keep people. So even though they're so skilled and love the work, I see people leaving constantly because it's hard to keep people when they know they could make $20 more an hour doing a similar job somewhere else, right? So I think, honestly, I think that would be a very innovative solution. I don't think I don't think visiting nurses have ever been paid equal. So it'd be a new thing to try, paying us the same. And I think it would actually improve outcomes. You wouldn't need a whole fancy retention strategy. I think it would actually just be part of the same package. You pay people what they're worth and people want to stick around. It's great work. It's honestly so nice meeting people in their homes. You get to meet their pets and their kids and their family and see what art they have on the wall, and you get this whole real beautiful picture of what their life is like. And I think that's such an incredible way to deliver care to people, and so it deserves the resources to be able to do that well.
Chelsea, thank you for sharing your experience. You know, I'm old enough now, I guess, to say, if I can't get it this way, I'll get it another way. Like, there are many, many ways to skin something. So I will continue to drive the concept of wage harmonization. It's very important to me. Anybody who has done integrated care well has dealt with this issue in other jurisdictions. So it's like a no-brainer for me. But if we can't achieve it as a wage harmonization initiative, another way to come at it is a significant partnership between hospitals and community care providers, so that when you hire your workforce, it is an integrated workforce and therefore an integrated compensation approach for that workforce. So what I would say to your organization is, if there are opportunities like that, looking at you, good hospital partners that you can partner with and maintain your autonomy and independence, of course, but I think you have to give it some thought, because we have to find many ways to come at a problem. And then one of the paths will open and we'll move through it. So long as we don't create inadvertent consequences with it, we have to be mindful of that as well. But now is the time to take those innovative steps and risks. And I appreciate your story.
Thank you. Actually, that's a great segue into, Leanne Bro. If I'll invite you to share. Leanne is a visiting nurse at VHA, working with University Health Network in the integrated care program. Yes, there you go. You read our minds. So Leanne, I'll hand it over to you. Could you please tell us a bit about your experience with UHN Integrated Care Program and how nurses are improving the client experience through the work with hospital partners.
Ooh.
Yeah, sure. So basically what happens is so we deal with cardiac surgery, thoracic surgery, and they've just actually added transplant patients. And basically what we do is the first 90 days after discharge, we look after the patient so that they can recover at home. And it's really kind of when it says integrated, it really is because I'm out in the community looking after the patient. I have an IC lead nurse within the UHN network at the hospital who's connected to the surgeon, oftentimes an NP as well as the cardiologist. And we're all looking at the same information and we're all sending through the same information as we're working along to bring the patient towards these goals. So, I often say to these patients, you're so lucky because you have me looking after you in the community. You've got the nurse in the hospital who's connected to a nurse practitioner, who's connected to the surgeon and a cardiologist. And it's really, I would say, I've worked in healthcare now for over 20 years, mostly in the pharmaceutical industry. And I just recently moved into nursing throughout the pandemic. And I would say that this is a program where we're exceptional in our healthcare. I know we see a lot of negative, but this to me is a program where I'm like, wow, like we're doing good. And so I think this is, in terms of community care, I think it's a place where we've put the focus on the community, and I think it's an exceptional program, and I love it.
Leanne, whose employee are you?
VHA.
VHA's employee, okay. So the wage harmonization thing still haunts you.
Well,
right?
It's interesting that you're talking about it because I actually come from the pharmaceutical industry where I've managed patient support programs and I became a nurse just throughout the pandemic to give myself sort of a goal and something to accomplish, and I didn't see myself retiring. And then I left that job to come and do this to get some clinical experience. But to your point, it's very hard to make a living. And whether I can sustain that or not, full time and maybe do this part time and go back to that is a real issue for me.
But here's another path through which we can advocate for the future we want, which is nurses need to be paid equitably across all sectors. So the other powerful path is the story, your story, and the data associated with that story. So data, as you know, speak volumes. But if you attach a story to it, like patient stories, the difference you made to people's lives, the skills you were using at the top of your practice. Imagine if we give you RN prescribing what you could do for your patient population, it would be just so compelling to say why things have to change. So I would really like offline to connect with all the right people, Sandra, as you see fit, but I'd love to understand this model further.
Absolutely.
And then to really more in detail understand the assessments, the interventions you are using, because you are obviously helping to take people out of the hospital faster.
That's right.
And then helping them recover in the community. It's very powerful, folks. And you must read the tea leaves. You see, this government cares about it. We've just come out of a pandemic. So it's very crucial, even when I'm positioning things for proposals for consideration, I always marry them to the things the government is paying attention to, because it's just politically savvy to do that. More and more, if we can portray your work as being very important to be removing people out of hospitals, preventing emerge visits, preventing ALC growth. Sorry, those are the things that matter to the government today. Tell your stories by framing it in those things that people are paying attention to, and they'll get the attention it needs. So amazing,
I think
amazing example.
A step in the right direction. Yeah.
Thank you for sharing.
Thank you. I know, Sydney, you have a comment?
Just a quick question. Thank you for sharing, Leanne. This was fantastic. And on what platform do you recommend that we share our stories, Doctor?
or you can call me Karima.
Thank you.
On what platform? Any platform. Like really, it's an activist mindset. It's the mindset of an activist, which means you lead from the place you find yourself in. And I've tried to do that all my life, whether I was a staff nurse or a nurse practitioner in oncology, or when I became an educator or an advanced practice nurse. It doesn't matter which role I played in which place. The activism in me has never left me, which is this relentless, absolute focus on the people we serve and anchoring everything we say in terms of how their lives could be better, using evidence where needed, but use the receptors that are in front of you. Sandra would be one place where I would say you could direct some of your advocacy. Catherine is another. They're right near you. And then with their help and aligned with them, some advocacy that gets directed to us, to government, and I'll be listening to you. So I've opened my door to you. You should knock on it again to have a second conversation. Otherwise, it will be a one-day wonder that we had here. So it's this idea of building this snowball until it takes a shape. And then use your professional associations well as well. Some of them are very effective in their approaches to advocacy, so long as you don't lose your voice and your perspective to them. Yeah, there's so many places in which you can, but I would say your work should speak for itself. Sharing your work should speak for itself. Start there so it doesn't feel so onerous and foreign. Just tell stories about your work whenever you can. Try to quantify your work. I saw 10 patients and made this difference. I prevented falls in the 4 of the 10 people I was serving, and I kept them aging at home. And then marry that with, some data that says, well, when you care for an aging person at home, it costs this. Whereas if you bring them into the hospital, the costs are 10 times more. 8 to 10 times more. So it's more cost effective to care for people, and we create better experiences. And that's where people want to age as well. So nurses and storytelling, we have forgotten this, the fact that we have experiences with patients, deep experiences. Don't forget to tell those stories, but just marry those stories a little bit with data, so it makes the case powerful. But start with where you are. You don't have to look far. If you start there, the snowball will start to grow.
Thank you for that. Thank you for that question, Sydney and Karima. I'd like to now ask Sangeeta Maharjan to share her experience. And you'll be very interested to know, Karima, that Sangeeta is one of our IENs. So, yes. So over to you, Sangeeta.
Thank you.
Thank you, Sandra. I have this example of clients living in a supported housing building who had a bed bug situation in the apartment for many years. During my visit, I found this client housing condition very unhealthy for this client to live in, and even for us to do visit. So client was very helpless and often cried that this is not her doing. I listened to this housing superintendent who reported client doesn't want treatment, and there have been unsuccessful attempts in the past. I listened to the client who reported doesn't want to live like this and is tired of the situation and doesn't want to complain. So I found the problem between the client and the service care provider. So I found out the client is not being informed about the treatment and follow-up treatment dates. And oftentimes the notice of entry is left at the door, which this client is not aware of, which resulted in the cancellation. Also, this client is unable to prep for the bug treatment or keep the required cleanliness due to functional decline and the cost related to this. And this client's previous experience was that she had to stay outside in the hallway in the wheelchair during the BOG treatment, which was more than 3 hours. And this client previous experience where all her belongings were tied up in a bag before treatment, and this client had no idea where to find even a single pair of clothes to change into or a pair of socks. So as a home care nurse, I was the first to listen and have eyes on this side of the ship. I spoke to the superintendent to arrange the treatment. I also communicated with the family member to plan for the day, for that day that a client must be out for several hours on treatment day. So I realized my effort walking to the housing superintendent office and the Sprint senior office and requesting wasn't that strong enough to initiate the treatment. So with my update to the home care coordinator, the family doctor, and the nurse practitioner, a quick inspection of the unit was arranged, and the pest control called it the worst infestation ever. And this is in Toronto. A couple of days turned to several days, no effective treatment could be carried out. And the outcome, a full scratch wound due to a bug bite resulted in a inflamed lower leg cellulitis, and this client ended up being hospitalized. Later, she was diagnosed with septicemia. So there was a big letter that came from the Sunnybrook Hospital to the family doctor office, indicating the lack of client care and a bug found on client's body. And there were the 2 cases with the bug infestation that happened in transitional care unit as well. So there was also an integrated meeting for bug control between Toronto Senior Housing, the pest control, home care, and the social worker from Baycrest, Sunnybrook, the family doctor, and the geriatric psychologist from Cabbage. In this case, the Toronto Public Health was involved laterally for finding the black mold and the all other health hazard in client's unit. And the latest update on this client has been in waitlist after being admitted to Sunnybrook Hospital transitional care for 3 months. And still in her apartment, some level of treatment has been completed, but still the baseboard not fixed yet. So still not safe for this client to come back. So my point with this client outcome is we, the home care nurses, we are aware of the dimension of patient-centered care. And despite knowing the risk of complication, not all nursing care we do is a success. I also want to highlight the complexity of the professionals and the agency having to be involved in this process. And this is just one single case. And there are more in our community. So this is my example. Thank you.
Oh my God. You know, as I was hearing your story, I was thinking it could be my mom. This could be my mother. If this was our loved one, what would we do? What would each person who had to interact and make that situation better do? Honestly, it's heartbreaking. Heartbreaking to hear that story, but thank you for all your diligence, your advocacy on behalf of this person, getting people around the table. Wow. Complex work. This is what I mean by complex work. You know, we've become very attuned to this idea of nurses have to be with acuity. That's why we've mostly put them in hospitals, because that's where the acute care patients are. And this waking up we have to do in nursing education and in other places to say, most people are, you know, at home. Interactions with hospitals are episodic. And we have to put more content in that curriculum for community-based nursing and all of these complex assessments and interventions you've just spoken about. Imagine. And you are one person trying to orchestrate all of that. I know there were a team of people, but can I ask, as an IEN, which country you came from?
From Nepal.
From where?
Nepal.
Nepal. That's amazing. Amazing. And when was that?
I came in 2015.
Wow. there must be a whole story behind that as well that we won't get into, but I'm sure what an experience that must have been. So thank you for sharing.
Thank you, Dr.
Happy to send all the bios to you, Karima. I had to edit it because of time. There's a long, I do have all the bios.
Wow.
I am conscious of time. We do have 9 minutes left. And we do have 2 more nurses who were planning on sharing their stories. And are we good to, maybe I'll ask them to shorten their story and just in terms of that piece, because I know we're running out of time. I think we will take you up on, the continuing conversation and discussion with the small group and, others who haven't had an opportunity to ask you questions. I know we have a slide that we can have the nurses submit the questions and we will do our best to get them answered. So if it's okay, because the 2 nurses have prepared, I will hand it over to Barbara to talk a little bit about the VHA's Tactical Healthcare Response Unit, and this will also showcase some of the innovation, some of the work that we have done. So Barbara, over to you to, in a minute or so, highlight what you were going to share.
Yeah, certainly. So I'm, as you said, a through team member, and here's what we're known by wherever we go. The through team actually came together to respond. It was VHA's strategy to respond to some requests for help with vaccination. So there were many nurses who had never worked for VHA or were not familiar necessarily with their programs that became part of a team that started to do vaccinations. And, something to be, I think, very proud of is we were mainly working in neighborhoods impacted by social determinants of health because vaccine rates were lower there. And we're also a totally nursing-led program. So that was very important that we were not dependent on physicians to be there present while we were vaccinating. We're a multidisciplinary team. And I think another really good thing about our team is we work very closely with community partners. So we worked a lot with Rexdale Community Health Center, Fred Victor Community Health Center. So we were, I think that was that is very rewarding. Currently, as one of the reasons we're called the Tactical Response Team is we're nimble. We're trying to be as nimble as possible. So we're able to move where need is. And since a vaccination has decreased or the need for it, we've been moving. We were working in cold and flu and COVID assessment centers, as well as wellness clinics, and also providing some support to individual family health teams. So that's kind of an example of our nimbleness. There's a lot of hurry up and wait. Like, oh, there's this project, but then it takes a lot of time for the reading to be, to be turned to blue. And then the other point I was going to make was, well, a lot of times, particularly the cold and flu centers, people didn't know we were existing. So it was, we were intended to be a diversion from emerge and walk-in clinics. And that didn't really happen, I think, because they didn't know we existed, right? So, these are things that we could remedy down the road.
Yes, and not to be hard on ourselves. We learn. Whenever we
well, of course,
innovate,
yeah.
it won't always, we will not always get things fast or right the first time, but we will
Uh-huh.
at least take that approach, that step forward, and we'll learn from it and do better next time. I'm very forgiving to myself in my old age. Like, I'm at least going to try. And if I don't get it right, I learn from it. That's the best I can do. So good for you to try.
Thanks.
Excellent.
Thank you. I'm wondering, Pessy, do you have 2 things you want to share with Karima? And I'm sorry, I know last but not least, Pessy is a nurse and clinical lead with a specialty in palliative care.
So I will agree with everything that Chelsea said about being in home care and being able to support people to die in their home, in their familiar environment. The difference in our teams is our team in North York, particularly, we have morning huddles every day with our care coordinator for 10 minutes. So the physician group from Mount Sinai, the Timmy Latner Center, who sees patients in their homes, are on the call with us. I cannot tell you how amazing it is to be part of the team that is providing this care, because the doctors really do respect the nurses. They trust our assessments. They take our recommendations seriously. The doctor will say to me, so what do you want to start the dose at, 5 or 10? Like, it's up to us. So when I'm hearing from you that nurses can have some prescribing, like, we're already doing it kind of backwards, because the doctors are asking us, what are we doing? How many days of IV hydration do you want? So that piece, because we're working with the same doctors every day, my geography is very, very tiny. So I really only work with most of the time with 2 doctors in the area. I keep my area small. So if my patients call me to come back an hour later, I can do that, because I'm not traveling all across the city to see other patients. I'd rather see them in that very small area. The nurses really run the palliative program, because they make the recommendations. They ask for the hospital beds, the commode, the other service providers like PSW, OT, the equipment. Everything is relied on the nurses, because we're the ones who are going in day after day. We've got the relationships with the patients and the families and the dogs and the pictures on the walls, and there's really nothing like home care. And I absolutely love the palliative part of it and watching these patients. My favorite will be when I'll tell the family what to expect, and I say, it's not like the movies, there's no drama, they're just going to stop breathing, nothing else. And afterwards, when I come back for the bereavement visit, and they'll tell me, you were right. Like, I didn't know what to expect. And really, it was just, they just went, and nothing happened. And then they call us, and the policies are all provided in advance, and the EDITH protocols, if needed, are done in advance. So it's so organized, it's so well done in North York. I know it's different in different places, but I absolutely am honored to be a part of the North York. I'm very happy to see people in their own homes when they call me for other things, because I'm used to not having all the supplies and figuring things out and bringing things in from my car. So I'm probably talking too much, but I could go on forever, but I'll leave it at that. I will say that I have every single card that every patient has ever given me, because when they tell me that they appreciated my work, I want to keep that with me.
Your passion is palpable. And thank you for that. Thank you for not losing it.
Thank you. No, I absolutely love it. And I've been with VHA for 15 years, so they're stuck with me.
Wow.
So thank you. Wow. You're all very inspiring. It's so inspiring to hear the stories, and Karima, for your time this afternoon. I know we promised David that you were going to be done by 3, and I better hold to that time. Otherwise, we may not get another chance to meet with you. But thank you again. Thank you to everyone for joining this afternoon. This has been incredible. Any last words, Karima? Over to you.
Invite me again. I have thoroughly enjoyed this. This makes my day when I'm interacting with people like this. It's just amazing. You have truly inspired me. And Pessy, you should ask the premier to come and spend some time shadowing you, because
Gladly.
I'm telling you, there's one approach is to go through a bureaucratic advocacy approach, and the other one is just to say, come and spend 2 hours with me and I'll show you the work we do. And this is a people-oriented premier. So I find sometimes we could use that to our advantage and say, let me come and inspire you. Let me show you what's working well. Human beings want to hear positive stories. When all they hear are woes, we are human, we stop listening to it. But if we can inspire them with, oh my gosh, look at this magical work we do, keeping very complex things at home. So powerful, folks. And please, I'm ready to be invited again anytime. So thank you so much for your time. And Sandra, thank you for facilitating such a good discussion.
Thank you. Thank you
Thank
to everyone. And
Appreciate it.
bye for now, Karima. And
Take care.
we'll
Bye,
join you.
everyone.
Bye. And just for
Thank
those,
you.
the nurses, bye, David, thank you. If you have any questions, please send them to communications@VHA by Friday morning, and we'll do our very best to get them answered. And I know Karima's gone, so thank you again so much for your time today. I do want to take just one more second of your time. I know we're 3 minutes over. Isabel, would you mind just going back to slide 3? Just would like to acknowledge and thank those who have really put this event together. I would say we started this last year, and looks like we will have more to come. So thank you so much, and it's been really wonderful, and hope to connect with all of you very, very soon. Bye now, and drive safely for those of you who are still out there.
Thank you,
Thank
Sandra.
you.
Have a great
Thank you.
day.
Thank you.
Bye.
Bye.
Bye, everyone.
Bye-bye.